Welcome to Speaking in Spoons with your host, Christina Brookman.
Hi, welcome to Speaking in Spoons, a chronically ill podcast. I am your host, Christina Brookman, and with us today we have Dr. Jeffery Boris, a cardiologist who specializes in dysautonomia. Hi, Dr. Boris. It's
Hi, how
lovely
are
to have you here after all these tries.
you? Glad this to work.
Huh?
I'm glad we could get this to work. Thank you for inviting
Oh,
me.
me too. I was so excited when I saw your publication this summer on POTS. But before we get into that, I would love to hear, and our audience, I would love to hear more about yourself as a physician and how you got interested in the area of dysautonomia.
Sure. So I'm a pediatric cardiologist. I finished my training 27 years ago. Seems like forever. And pretty quickly so the United States Air Force paid for my medical school. So, and they also paid for my pediatric cardiology training. So I owed them 7 years as a pediatric cardiologist. So my first assignment was to be the pediatric cardiologist for the US military in Europe, stationed in Germany.
Okay.
Quickly kind of got interested in taking care of patients with syncope, passing out, and found some unique things about certain types of syncope and just kind of interested in it and was having pretty good success with it. And then moved back to the States and was in Mississippi at an Air Force base. In 2002, had a young lady who came to me with lightheadedness and syncope, and she just wasn't responding to all the typical therapies that I was trying, and she just had all these other symptoms. And so I'd heard of this POTS thing before and did a little bit of looking in the literature. And this name kept popping up in the medical research, which was Blair Grubb.
Mm-hmm.
So I found him at the University of Toledo. At that time, it was Medical College of Ohio. And I cold called him. Hi, you don't know me, but, and we ended up chatting on the phone for 2.5 hours. I mean, he was just wonderful. And he and I are still very good friends today. But he
I
sort of,
love Dr. Grubb.
yeah,
Um, I remember you telling me that's how you got interested in he's the was the first doctor to treat me with POTS. So it's very exciting to hear. Please continue.
yeah. So, I saw a couple more POTS patients when I was in the Air Force, finished in 2004, was in private practice briefly in Western North Carolina, actually in Asheville, the place that just got
Okay.
hit by Hurricane Helene.
Yeah.
3 years, saw a few patients, POTS patients there, and then joined the Children's Hospital of Philadelphia in 2007. And not long after I got there, I said, by the way, I know how to take care of POTS patients. And she said, are you sure you want to tell me that? And the heavens slowly opened up. First, my cardiology colleagues started sending them, and then the diagnostic center started sending them, then the neurologists, and then the gastroenterologists. And so it got to be quite the flood of patients. I ended up creating the POTS program at CHOP in 2014, and that was open for 4 years. Had a wonderful nurse practitioner working with me, and we saw a lot of patients. We created probably the largest pediatric POTS database in the country, if not the world, almost 950 patients.
Wow.
And I started publishing research at that time because I just felt like POTS patients were, were being ignored. And I think there was a lot of ignorance in a lot of locations, both locally and globally. And so I just wanted to kind of get stuff out there and say, this is what we're seeing. This is how the patients are. This is what they're experiencing. And so have been able to really put a lot of research out into the field. And then I left Children's Hospital in 2019 and opened a private telemedicine only practice in 2020 during the pandemic. And so that's what I'm doing now.
And it's interesting that you discuss the fact that you felt that patients weren't being heard. I got so spoiled initially having Dr. Grubb, and then when I ended up in a different state, I started to realize how other people with POTS were having such a hard time getting adequate care and being heard, and to hear it from another, like from a not another, I am not a doctor, but to hear it from a doctor that they have seen that is very validating.
Sure.
How has it been as a doctor trying to communicate to other doctors that you feel patients aren't being heard? How has that been received?
I think it's variable. I am in a lot of ways sad about how the medical community in many ways has been, especially since, as I'm sure your listeners know, overwhelming percentage of POTS patients are female. And so historically, for decades and decades, patients have been marginalized by the medical community, right? So you go back and you look at patients who had multiple sclerosis, and until the advent of CT scanning that actually showed that there were lesions in these patients' brains, these people, these poor women and girls were told that they had hysteria, right?
Yeah.
And so it's sort of the same thing. I think that are there some physicians who have an open mind and who are willing to actually look and see what's going on? Sure. I think those are the ones that are more interested in really taking care of it. But I think a lot of physicians, for many reasons, because either they're overwhelmed with work or because of other kinds of pressures, I'm not sure, very much feel like they understand everything they need to know about their job, and they don't need to learn more. And so it's really unfortunate. So either what will happen is, if there is a POTS patient that comes in, they'll say, well, I don't believe POTS exists. And by the way, your heart is fine, so go away. I mean, they don't say go away, but
Yeah.
so I can't find anything wrong, you're fine.
Right.
Or they say that you have anxiety, or they say that your parents are doing something to you, Munchausen syndrome kind of thing.
Pseudo seizures.
Or just some other
Yeah.
thing. When I was at Children's Hospital, I made it a point to go around to the various divisions, neurology, emergency department, physical therapy, adolescent medicine. I wanted them and give talks on POTS. This is what this is. This is what we're seeing. This is what the patients are experiencing. You need to be looking out for it. And it's not just something that is that's something that you can just kind of cast aside and say that, well, it's a psychiatric problem. It's not.
I think we talk about that a lot on the podcast too, that it seems so many things get thrown into the world of psychological psychiatry when it's the unknown, instead of just saying, I don't know, or let me refer you,
Right.
Which is fascinating to me, because science is always changing and evolving, and we learn new things,
Sure.
with research. Um, do you think, I'm just curious, do you think there needs to be a change in the way we look at education in the medical profession?
I think so, but um, I think we need to also understand, we need to keep in mind that physicians are human,
Yes.
right? And we have a lot of hubris. Um, and I think that, having humility and recognizing that is incredibly important. And I think a lot of people sort of forget that. They get the rewards of taking care of most of the patients that they can see, and they're just like, yay, me. To your point about, modifying education, there are attempts being made to change um, what's being taught in medical school with regards to including things like autonomic disorders and that kind of deal.
Oh,
I I think to keep in mind though, the way medical school works is medical school is 4 years long, right?
mhm.
The first year, and different schools work differently, but by and large, the first year you learn how the body works. The second year you learn how the body doesn't work. Plus you learn about the physical examination and getting a history and that kind of thing. In your third and fourth year, excuse me, your third and fourth years are spent doing clinical rotations. So yes, you learn a lot, on the floor, seeing patients and being able to include what you've learned in your first 2 years in the care of patients. But I mean, you know, we have learned so much more than the time, I graduated medical school well, 1991, right? So 33 years ago. Oh boy. And
Right.
and so we know so much more about how the body works, which doesn't mean that we know everything. But how do you fit that all in? You
How do
know,
you?
I
And
mean, and I think part of what really needs to be emphasized that isn't necessarily emphasized is that we as physicians need to be learning always, need to be continuing to maintain
yes,
our education. And
continuing education.
the
Yeah,
the board certification demands that, but there's ways that you can just sort of, in a way, kind of short circuit that system and say, well, I'm learning stuff I already knew, and oh, great, I
right.
passed all my tests. There you go, I'm good. So it is difficult.
That's that's interesting, though looking at the continuing of education aspect. Um, I've often wondered how that works. Because you mentioned there's ways to kind of like fudge your way through, not fudge, I mean,
Right. Right. Sure.
but to not really, it would be wonderful if there requirements about, going to conventions, reading such and such, like reading certain amounts of updated, um, like your research, things like that are coming out, like how,
So nothing specific. What
okay,
you're required to have a certain number of continuing medication education hours per year.
okay,
Doesn't say in what field. It does say that it needs to be this much in what's called category one, and then this much in category two. Category one is like going to a conference or participating in it. Two is participating in online seminars or doing medical legal reviews or doing journal manuscript reviews, all of stuff. Well, those are all things
okay,
that I do. And but it doesn't say you need to do X number of
right.
hours in autonomic medicine. I mean, it just doesn't work that way,
Well, and there's so many different things out there to explore, so I could imagine that would be,
So
yeah,
it's whatever catches your eye, right?
right. Um, as which leads me to what you're currently doing. I've seen kind of pop up here and there with different doctors as doing online consulting. And I'd love for you to talk more about that because I think that may open up a way to kind of bridge some of those gaps with education and work with doctors in areas where there may not be that training. And I'd love to know your experience with that and what
Yeah,
drove you to it and how it's going.
sure. So when I when I left Children's Hospital in the spring of 2019, the other two children's hospitals in the Philadelphia area, one of them didn't have any open positions, and the other one actually went bankrupt right around that time, and then the
Oh,
pandemic.
yeah.
And so it was just looking like it was going to be next to impossible to have an in-person pediatric cardiology job. And my wife and also another friend both came up with the idea of, why not do a telemedicine clinic and do something
Mhm.
like that? And so I looked into all of the aspects of how to how to create my own clinic and how to do telemedicine and all that good stuff. And so my practice has now been open for 4 years. Um, I have multiple licenses in multiple states. The way it works is that for telemedicine, you have to be licensed in the state where the patient is physically located. So I can be anywhere, but the patient has to be in a state where I'm licensed. That's fine.
Okay.
So, so if the patient drives to that state, or if the patient is already there, then that works.
Oh, so they don't even have to live there. They can literally drive to the state.
They could drive, find some Wi-Fi, do it from their car, do it from a library, do it from wherever. Yeah.
Talk about accessibility. That's amazing.
Yeah,
Yeah.
absolutely. Well, and so that's for the patients who are out of state. But the patients who are in state, it's really convenient because they can just do it from their living room, from their
Yeah.
kitchen.
I do most of my appointments telehealth, and I found that extremely um, uh, helpful because, as you've seen when we've tried to do the interview before, I'll get that right-sided weakness and difficulty speaking
Mhm.
and going to places with the bright lights and the sounds, but also the physical exertion
Right.
triggers that. So telehealth, and I know with a lot of people that I talk to in the support groups and stuff, it's really beneficial because it's so hard to just physically get to an appointment.
I think it was really interesting prior to the pandemic, both physicians and patients were just down on telemedicine. They were not really
Yeah.
particularly thrilled about it. And I think it wasn't until the pandemic hit and forced people to really start using it and they recognized, wow, this is really a helpful tool. Now, one of the things that happened was there was a temporary federal relaxation of the telehealth laws such that you didn't have to be licensed in that state and you could see patients during the pandemic.
Okay.
Um, so I did not take advantage of that because I knew that that was not going to be permanent. And so I didn't want to leave a patient in the lurch, say, sorry, now you've got to,
Yes.
travel X number of states to come see me and that kind of thing.
How do you monitor and because dysautonomia often deals with like blood pressure, heart rate, changing positions. How do you work with patients via telehealth?
So the large majority, honestly, is not as much the physical examination, but the history. The
Okay.
history is so important. And then the education piece. Having said that, from an evaluation standpoint, most people anymore have either an Apple Watch or a Fitbit or a pulse oximeter or a blood pressure cuff at home. And
Mm-hmm.
so, I mean, if I need to do a 10-minute standing test, I give them the instructions. I will keep time for them. And I'll say, okay, we're going to have you go ahead and lie down for 5 minutes. At the end of 5 minutes, we're going to grab your heart rate. And we'll have you stand for 10 minutes, and once a minute, we're going to grab a heart rate, and, no leaning on anything, no talking, minimal stimulation, no phone, no nothing. It's going to be really boring. And and then I just go ahead and cue them once a minute to measure, and it works out fine.
That's interesting.
And then there are a few things that I can do visually that I can assess the patient.
Or in that 10-minute or
just even in talking with them. I mean, even I only do a 10-minute standing test if a standing test has not been previously performed, or a tilt table test has not been previously performed.
Okay.
If it has, when we have documentation, then I'm okay. We don't have to repeat that. And I don't do it routinely because there's no evidence that repeated 10-minute stand or tilt table testing, for that matter, has been shown to be beneficial in assessment of therapeutic intervention.
Okay.
Yeah.
Speaking of research, I would love for you to share with our listeners your current research about long-term outcomes.
Sure.
And how you got into that topic, and then what you saw.
Sure. In 2016, the folks at Vanderbilt University and in combination with Dysautonomia International published a really great study that was called The Face of Postural Orthostatic Tachycardia Syndrome, or The Face of POTS. And it was an online only study where Dysautonomia International and then with the help of Vanderbilt put together a questionnaire, a large questionnaire and survey, and they gave it to, with obviously permission, gave it to several thousand patients, both adult and pediatric, online. And so they published that first paper, and they've actually had several other papers come out from that. And one of the things that has happened is that there have been 6 other long-term outcomes type of papers that have been published, 3 from the Mayo Clinic and 1 each from Italy, Portugal, and Korea. And in various ways, those studies have been a little bit problematic. They have said, all of them have said that POTS goes away. And that POTS patients get better and they do fine. Have a nice day. And those of us in the field who are taking care of these patients are like, that's not right. That's just not right. And so I was lucky enough to get a copy of the questionnaire that Dysautonomia International and Vanderbilt used, and also got a copy of the questionnaire that the last questionnaire that Mayo Clinic used. And so I adopted a lot, if not all, of their questions, and added some others of our own.
Okay.
And what we did was we went to our database and found that of the almost 950 patients, 843 had valid email addresses and met criteria. They were diagnosed at age 18 or less by me or by one of my colleagues whom I know knows how to do this, and then were followed by me or the nurse practitioner. And so I knew that unlike that prior study, the Face of POTS study, which was self-reported, this was a study that these patients were actually diagnosed with POTS.
Right.
Okay, so that's a little bit different. And so what we found was, of the 843, 227 filled out the survey and gave us enough information to be able to interpret a lot of the data. And so The average age of the patients was almost 22, 21.8 years. The average duration of symptoms was 9.5 years from onset to the time they took the survey, so pretty long. And we asked a ton of questions, a ton of questions. We looked at how it was getting their diagnosis, their evaluation, their treatment, their outcomes, quality of life, that kind of thing. We also looked at educational, employment, and social outcomes. And we also looked at gynecologic associations. Those last two sets of data have not been published yet. We're cleaning up those manuscripts for submission. But in the first one, which was diagnosis, treatment, and clinical outcomes, we found was that this was sort of surprising and not surprising. We had a list of symptoms and we said, okay, here are the various symptoms. Did you ever have these symptoms? If you did have these symptoms, on a scale of 0 to 10, how bad, where 0 is none and 10 is the worst, how bad was it when it was at its worst? How bad was it when it was at its least? How bad was it last month?
Oh, okay.
And the one for last month was surprising because what we found was 99.1% of all patients were symptomatic last month.
Mm-hmm.
And that was the breakthrough. That was like, wow, that really blows away everybody else's stuff.
Yes.
It's not, and the average scores when they were at its worst was like, or the range was like 7 to 10. Okay, so pretty bad. At its least, their symptoms were like 0 to 4, right? But for symptomatology last month, the range was 2 to 5. So that's not nothing.
No.
It's not nothing, which means that patients can be helped, right? They can have their symptoms improved, but it doesn't mean they're going away. What we also found was that female patients had more symptoms, more severity of symptoms, and had symptoms for longer than male patients.
Can you say that again? Because there was a breakup, and this is really important, I think.
Yep. So female patients had more symptoms, more severity of symptoms, and symptoms for longer as compared to male patients.
That's really interesting.
So, that we had the typical evaluation stuff. 2/3 of patients were told it was in their head. A lot of them were told that they had a psychiatric disorder. Although interestingly, after their diagnosis of POTS, as many as almost 40, I think like 43% of patients still had a psychiatric disorder. There was a prior paper that was published from Vanderbilt also some years ago that suggested that the prevalence of psychiatric disease is not any higher than that of the general population in POTS patients. But I think, so we can certainly see anxiety and depression and OCD and those kind of things in POTS patients. It's just not the cause of their POTS.
Right.
And the POTS patients can tell the difference. They're like, I know when I'm having anxiety versus when I'm POTSy, right?
And that's such an important distinction, that it can exist.
Correct.
And it make it worse, but it's not the cause.
Right. Exactly.
Yeah.
Exactly. So there were a bunch of we went through, evaluated a bunch of medications and also non-pharmacologic interventions. And in the big picture, the three main things that helped the most, or that were felt to help the most, were medications, increased fluid and salt, and exercise. Those were sort of the three biggies. There was, about 15% each of 15% each of patients felt that like a gluten-free diet or a dairy-free diet was helpful for some of them. And that's fine. That's great. We found that 21.5% of patients reported having mast cell activation syndrome. We asked about Ehlers-Danlos syndrome, Ehlers-Danlos syndrome. We didn't ask about any other kinds of joint hypermobility,
Okay.
either hypermobility spectrum disorder or, or any kind of other specific disorders. But there's a significant number of patients who had joint hypermobility as well, or EDS as well. So,
That's
there was a lot.
a lot of connections. That's really interesting um and exciting too. Just a lot of the things you are talking about, as a patient, feel very validating. And that kind of sometimes, like, I know a lot of people talk, labels are bad and all that stuff, but sometimes for a patient, labels or hearing results kind of, they validate your experience,
Right.
and that it's not in your head, and that
Right.
how do you see this research um uh affecting the community and science in the future, and where are you looking to grow with the research? Kind of a convoluted question, but
It's not a convoluted question. It's just hard to answer. I think,
yeah,
whenever anybody puts research out there, into the atmosphere, as it were, it develops a life of its own. And sometimes people pay attention and sometimes people don't. I think there are a number of people in the field who have, paid attention to it. I'm actually going to be presenting these same data in next week at the American Autonomic Society. And I think that getting that word out is all fine and well. I think there are a lot of people, even amongst autonomic providers, truly, that they're very happy to talk about things like multiple system atrophy and pure autonomic failure and Parkinson's and Lewy body dementia and diabetic autonomic neuropathy. But when it comes to POTS, they're just sort of like, oh, yeah, right, the ugly stepchild. And
yeah.
they don't want to accept that as a dysautonomia, much less any kind of disorder, and try to come up with all kinds of ways to discredit its presence.
Which is so unfortunate. It's I have also noticed, and I've heard other people in the community, once they have a diagnosis of POTS or Ehlers-Danlos, there's the almost, oh, you have that, and then people stop looking at other possibilities of anything else.
Sure.
Just because I have POTS doesn't mean, I can't have, a cold. And the POTS doesn't cause the cold, or things like that. They're actually looking at some other genetic testing for me, and for years it's I think been hard. A lot of doctors get overwhelmed by the POTS. So I'm
to your point, I think
yeah,
you're right. I mean, I think a lot of providers sort of see the POTS thing and then they just sort of freeze. They're just sort of like, okay, well, that's the etiology of what's going on. In reality,
right.
there are a lot of comorbidities that can occur with POTS, joint hypermobility or connective tissue disorders, mast cell activation syndrome, median arcuate ligament syndrome, craniocervical instability, small fiber neuropathy. I mean, there's on and on and on. We could sit here and
So
just
much.
spout off all afternoon. And it's, it's understanding what the clinical manifestations of these various disorders are for now, and to be able to discern, is there something else going on? Is this part of it? That kind of thing. And it's hard, as you and your listeners know, because we don't have a biological marker that we can use for POTS, right? And so, we're still using, a combination of symptomatology and increase in heart rate. And I'm hoping in the next 10, 20 years, we'll have better research that will allow us to pin this down so we can figure out exactly what's going on. And it very well may be that there are multiple pathways to POTS, all roads lead to Rome.
Right.
And it may not even be about the POTS. Could it be about the joint hypermobility? Could it be about the mast cell activation? Could it be something completely different? Is there an autoimmune disorder that is then leading to all these other changes
All
that
these other
manifest
changes.
in certain ways that different patients are genetically susceptible to in different ways?
That's fascinating.
Okay.
And I know a lot of us show inflammation markers and is there, as patients, are there things that we can do when we come to appointments to help make our appointments go smoother and maybe not seem like the ugly step-headed, child, and to have better relationships with our providers, so that we can work together as a team?
Um, it's a great question. I would turn that on its head, to be honest
Okay.
with you. I would turn that on its head. I would look to assess how willing the physician or nurse practitioner or physician assistant is to work with you. How willing are they to accept that you have these symptoms? How willing are they to accept that, your connective tissue disorder, your POTS, your mast cell stuff may be causing these various symptoms? How willing are they to validate the term that you've used, as well as to say, okay, either I don't know, but I will find out for you, or I don't know and I will get you to someone who does, or you are working with somebody like me, and saying, when I give a bunch of recommendations, both non-pharmacologic and pharmacologic, saying, wow, thank heaven somebody knows what the heck they're talking about. Just tell me what to do and I'll do that. Okay.
Yes.
And I've been, I think, at least from my practice, I would say 90 to 95% of the primary care providers or even specialty care providers have been really good about that. They've been like, cool, someone has given some recommendations. The notes are incredibly thorough and complete. And this person seems to know what they're talking about. So let's go with it and see how it goes. I think, and I think I would have a low threshold to, if patients are being given the runaround, or if patients are being, gaslit or whatnot, kick that provider to the curb and find somebody else, with the understanding
Yes.
that, yeah, it does make you look like you're doctor shopping, and I get that. But by the same token, I think you just have to come forward and say that my doctor that I was with before wasn't really particularly familiar with how to take care of me. So that's why I'm seeing you.
Yeah. No, it's just refreshing hearing that from a doctor, that you're actually the first doctor I've gotten to interview, and this is exciting, and affirming, and because I've said that so many times, it's like when you shop for shoes, you have to make sure it fits, and it should be a partnership, and it's a partnership for the doctor too. Doctors have patients where it's not going to work out.
Sure.
But they should be, you want someone who's on your side,
Right.
who can admit, I don't know it, who can do some research or help connect you to someone, or take information from a doctor that's, just 100% to everything. And just thank you for coming on here and saying that. It's just I know our listeners, and viewers will be excited to hear that, not just for POTS, but for many chronic conditions and disabilities.
Well, and I think,
Yeah.
in that vein, and to, using the fit, the fit of the shoe, I say the same thing to my patients who are getting counseling for their chronic illness. One of the things that I
Yeah.
recommend for all my patients is, because you have a chronic illness, and this is a statement I've heard Dr. Grubb say, none of us are born with the tools in our toolbox for dealing with chronic illness. And so
Yeah.
I recommend my patients do work, the patients and families work with somebody who's familiar with treating chronic, or just helping manage chronic illness. It doesn't mean you're a bad person. It doesn't mean you're a failure. It just means it's like you're going to school.
Getting those tools.
And you are getting a bunch of tools to put in your toolbox. Having said that, if you have to have somebody whom you trust and somebody with whom you feel comfortable, because if you don't, then again, it's bad fit, and you
Yeah.
need to be able to work with somebody who you can say, look, this is problematic for me. How do I do this?
Yeah. Um, uh, and for followers, and we are going to have Dr. Boris's information on the website, and at the end of this episode, and you can learn too. You are going to be doing a webinar, right, for Dysautonomia International, and it's a free webinar, and we'll have that information up. He'll be speaking more on this recent research study, and you can have the opportunity to, I think at the end, they'll have like a Q&A as well. Yes, which is always exciting. Do you have any final thoughts that you would like to leave our guests with, or viewers?
Yeah, I mean, I'm continuing to practice and see patients, and and I'm available to see patients. I'm also continuing to do research and get stuff out there. We got 3 sizable private grants to look at genomic linkages with POTS as well.
Cool. Yeah.
And so that's some data that I'm going to be presenting at the American Autonomic Society as well next week. And we haven't gotten that published yet, but hopefully pretty soon. And
Well, we'll have to have you back on to talk about that once it's published.
Sure.
And you can.
Sure. And it remains fun and interesting. I always look at different ways that I can evaluate the data to make it beneficial for the patients. I just published another paper actually a couple of months ago also, where we looked at patients who had in their 10-minute standing test, their peak heart rate didn't go above 100, yet they still had a 30 or even 40 beat per minute increase in their heart rate. And then we compared those to patients whose peak heart rate on the 10-minute standing test was greater than 100. Okay. And what we found was, besides tachycardia and tachypalpitations, feeling that it was really fast, there was no difference in symptomatology between those 2 groups. So it's really interesting where you look at patients who still have a quote tachycardic response, but don't actually meet the criteria for true tachycardia. And I think the word tachycardia has several connotations. So and several true meanings. So it's just really interesting. But we've published on family history, we published on demographics, the use of medications and stuff like that. And a lot of that is on a lot of access to that is on my website.
Okay. Which we will include too.
Yeah.
As well. This may be opening up Pandora's box right at the end, but you've mentioned several times that symptom that it is more POTS is more prevalent in women than men, and that symptomology can be more severe.
Sure.
Do you what do you think the cause might be for that?
Yeah, exactly. Actually, before I even go there, We also published a 3-patient case series of 3 transgender males transitioning from female, who, when I first saw them, they were doing fine. Their POTS symptoms improved with typical non-pharmacologic, pharmacologic, and exercise interventions. And then they started taking exogenous testosterone as part of their transition, and their symptoms just dropped off the table. It is
Wow.
not to suggest that patients should use testosterone, all the patients should use
Right.
testosterone, right? But I think it's just and further emphasis that there is something that happens with the presence of estrogen. I'll get further anecdotally, in our gynecologic outcomes paper, which again has not been published. 72% of the girls and women had worsening of their symptoms, their POTS symptoms around their periods. 98% of them had worsening. The worsening occurred in 98% of them, either in the 10 days prior to or the 5 days during their periods, right? So the overwhelming amount or percentage of patients were having symptoms either before or during. And we don't have data for this, but anecdotally, we can say that a fair number of patients, if they use a low estrogen containing hormonal contraceptive, either an oral or an IUD with hormonal contraceptive,
Right.
can reduce their severity of their POTS symptoms as well. So, estrogen, the presence of estrogen specifically, I think, plays a very significant role. And I'm not an endocrinologist, and I don't understand all of the molecular biology on that one, but
interesting.
I think there's something to be said for how that plays in. We already know that female patients are more represented in autoimmune disorders, more represented in joint hypermobility, more represented in myalgic encephalomyelitis, chronic fatigue syndrome as well. So there's something going on, and those may all overlap. To be honest with you, those all may overlap. So I don't know the mechanism. That's for somebody smarter than me.
Or just for more research down the road, in collaboration. Thank you. Thank you very much for coming on today.
Sure.
And we look forward to having you back in the future. And for followers, after this episode, we'll have information to Dr. Boris's website and how you can get to the article as well, and information for Dysautonomia International's webinar next week, where you can sign up for free to listen to Dr. Boris and participate in a Q&A. And
actually, one thing I wanted to say,
Sure.
That long-term outcome survey paper that we published in July, it's in the Journal of the American Heart Association. It is open access, which means anybody you don't have to have a subscription. Anybody can have access to it. Dysautonomia International was kind enough to pay for the publishing costs for that. So I thank them greatly. And so not only can you not only can you see the abstract for it, but you can see the entire paper with all the
entire paper, which that's rare. So that's for everybody to be able to do. That's exciting. That's really exciting. So thank you, and followers, stay tuned, because we'll have a follow-up discussion with our panel of spoonies in a future episode. And save your spoons.
If you want to contact us, please send a DM or email to speakinginspoons@gmail.com with any stories you have or would like to interview with us on any of our upcoming topics. And check out our website for all of our upcoming episodes and what's happening in the Speaking in Spoons community at www.speakinginspoons.com. Thank you for listening to Speaking in Spoons, and have a great day.